Sarah, you want to go over the combination data?
Yes, absolutely. So we now also have 2 phase 3 trials that have looked at oral SERD combination strategies, the first being EMBER-3. EMBER-3 had 3 arms. It had physician's choice endocrine therapy. It had imlunestrant monotherapy and imlunestrant abemaciclib. And imlunestrant abemaciclib versus imlunestrant alone were compared, showing a median PFS of 9.4 versus 5.5 months. In the patients that had previous CDK4/6 inhibitors, the median PFS was 9.1 versus 3.7 months. And in the ESR1 mutant subgroup, it was 11.1 versus 5.5 months. Now, there's certainly some tolerability considerations with the doublet, any grade diarrhea being 86% for the combination of abema and imlunestrant. And then we've also, in the last year, seen data for Avera, which is giredestrant plus everolimus, versus standard of care endocrine therapy versus everolimus. And this was a positive study, median PFS being 8.7 versus 5.5 months. But it really shined a bit more in the ESR1 mutant population, which is the theme that we've been seeing, median PFS of 9.9 versus 5.4 months. And they showed a post-hoc analysis where they took out the non-ESR1 mutant patients, and there really actually didn't seem to be much of a benefit. So I do think that most of the benefit here is being driven by the ESR1 mutant patients. Then, of course, for any doublet, you're adding toxicity. So we see some stomatitis, some mild GI side effects. So imlunestrant and abema are actually in the NCCN guidelines as something that you could consider in certain situations, I think is something that it says. We don't have giredestrant and everolimus approval yet. But for the patient that we discussed, she is not somebody that I think a combination would be necessary for due to all of the reasons that we discussed. So those are the 2 phase 3s. Should we talk about some of the other data that we have?
We should, but let me ask everybody here. So eventually we will likely have combination therapies, and obviously we have single agent therapies. In just your general HR-positive metastatic breast cancer patient post-CDK4/6 inhibitor, a show of hands, who would want to use combination versus single agent? Combination? Anybody else? 2 people, combination, everybody else going to use single agent? A couple more hands are kind of, okay, who's going to use single agent? Okay, so let me poll you guys. What would you use, Nadia?
I mean,
assuming you have all of these options available.
Yeah, I mean, in the patient we're discussing, I would use single agent, no question there. But there are patients with a shorter response to the prior endocrine-based therapy and maybe some more aggressive progression of the disease. And from my gut feeling, I would feel more comfortable with a combination, although I know that the data actually from the Emerald trial, if you look at the co-mutated patients, they're quite similar to what we see in the older combination trials. So I think that it probably, we have our experience in a more aggressive progressing disease. I would feel more comfortable with the combination.
Mm-hmm. Antonio, what would you do?
I would use a single agent in this patient. I think there are factors related to the patients and factors related to the disease. So in this patient, she's more than 65. She responded well to the first line, bone-only disease. I would prefer to give a single agent.
Mm-hmm. And has anybody in the audience used the combination of imlunestrant and abemaciclib yet? I know not approved by the FDA, but endorsed by NCCN guidelines. Not yet? On a trial, okay. So both of you have, I have as well. And it's interesting, so what I'm hearing from you, and I have the same feeling, is that you're picking combination versus single agent the way you would pick combination versus single agent for chemotherapy in a different type of patient. A little more aggressive disease, a little more unsure, maybe more symptomatic disease, you'll probably go for your combination, knowing the toxicity from that treatment would be a little bit worse. A little more indolent disease, you would go for your single agent approach. Yeah, no, that makes perfect sense. Okay, let's look at.
Pretty simply, do I need a response or not? You know, because we even have some bone-only patients that, you know, they progress and they have bone pain. You know, the patient that I reached for Imlu and Abema, she had 3 fractures due to her bone mets. And you know, her tumor markers were going up. She had dual ESR1 mutations, but I really just felt like she needed a doublet. Yeah. So do I need a response? The response rates are higher with a doublet than a singlet, is probably the main thing for me.
So when we look at this data, what surprised me when I saw EMBER-3 was that the benefit was both in the ESR1 mutant subgroup and the wild type. Whereas with Avera, Sarah, as you mentioned very, very nicely, the benefit was really only in the ESR1 mutants, which is what we've seen with all of these oral SERD strategies. Any thoughts of why the EMBER-3 trial it looks like it's an outlier?
I mean, it's a switch to Abema, you know, and a switch to an oral SERD. So it's sort of this dual switch strategy in a patient population who mostly had not had prior abemaciclib. So we're really, you know, we're changing the experimental treatment to two different therapeutics. I think there's a lot to overcome in terms of resistance after progression on CDK4/6 inhibitor. You know, ESR1 is one mutation and resistance mechanism that we're trying to isolate, but there's also CDK2, RB, you know, PIK3CA pathway. There's just a lot more to overcome, and abemaciclib is a dirtier CDK4/6 inhibitor. It has CDK2, CDK9. You know, it has a lot more inhibition there. And so that would be my guess. And they're also just very different trial populations.
Yeah. So you're basically combining through EMBER-3 both post-monarch and the single agent arm of EMBER-3. Yeah. Okay, let's look at the other combination data.
Here it is. Let's see. So we have also seen data for the phase 2 ELEVATE study, which took patients with estrogen receptor positive, HER2 negative breast cancer with 1 to 2 lines of prior endocrine therapy with or without a CDK4/6 inhibitor. Prior fulvestrant was allowed. Primary endocrine resistance was allowed. No prior chemo. Now these people did have to have greater than or equal to 1 measurable lesion by RECIST, or they could have a mainly lytic bone lesion. And so this is a multi-arm phase 2 study of elacestrant really combined with all of the targeted therapeutics that we use in the post-CDK4/6 space, alpelisib, everolimus, palbociclib, ribociclib, and capivasertib. And so we've seen data now for elacestrant plus everolimus, and elacestrant plus abemaciclib, as well as at this meeting, we will see elacestrant plus capivasertib. And so I can show you the data now for elacestrant and everolimus and elacestrant and abemaciclib. In terms of elacestrant and everolimus, 50 patients were treated. In terms of the number that had prior visceral disease, it's over half. In terms of whether or not they had ESR1 mutations, there was good representation for both ESR1 mutant and ESR1 wild type, as well as PIK3CA mutant and wild type. So to go back to the original question, in these trials, patients could be ESR1 mutant or wild type. For elacestrant and everolimus, we see a median progression-free survival of 8.3 months, an overall response rate of about 20%. For elacestrant and abemaciclib, we see a median progression-free survival of 14.3 months, an overall response rate of 24.6 months. And I don't see it listed here, but not all patients had a CDK4/6 inhibitor. I want to say somewhere between 60 and 70% of patients had a prior CDK4/6 inhibitor, which is worth noting.
So one of the questions here that we tried to answer initially was whether the benefit was only in one subgroup of patients or the other. And we're going to have data for the abemaciclib cohort, but for the everolimus cohort, it looked like it really didn't make a difference whether somebody was ESR1, had an ESR1 mutated or wild type disease, which is nice to see. So based on that data, anything that you would do differently, would you? Now, there's another thing that's important. The dose for everolimus here was 7.5 milligrams, whereas with the Evera trial, it was 10 milligrams. And this really highlights, and Antonio, how important the initial phase 1 work is. It highlights that we should really not be combining agents that we don't have data on.
Absolutely.
And you know, we have everolimus now, data with 10 milligrams, 7.5, 5. People use it any way they want to. But unless we generate safety data, we shouldn't just all say, well, you know, it's an oral agent, we can just combine it with anything. That's really an issue, right?
That's really important. That's why phase 1 study are the most important studies.
Yes.
Totally, and you know, we do that actually in the clinical practice. We do most of the time do not start patient on 10 milligram of everolimus even for standard of care. We try to taper up the dose. We start with a reduced dose to see how they tolerate. You know, this has to also place in the context of an umbrella study where it would be very cumbersome and lengthy to incorporate a phase 1 portion. So the study that there was actually, I feel like a very smart decision to actually start with a lower dose. When you are using two drugs that seems to be synergized and work on a mechanism of resistance, it is super smart to reduce the dose of both drugs so you can mitigate the tolerability of the combination.
Nadia, how does it work in Europe? If you have phase 2 clinical data with activity and you have 2 approved agents, let's say everolimus and elacestrant or abemaciclib and elacestrant, are you free to use them as in combination, or do you have to go with just the approvals per agent?
We're not free to use them, but I think Elevate is a great program because it gives us sort of safety and a glimpse at efficacy. And if you put that next to the larger phase 3 trials, you see it actually not that much different. So there's a principle there. It works and it's safe to combine. And I think we cannot possibly have phase 3 trials. Now, with all these different agents, we're lacking evidence for the line of therapy as well as combinations. How can we possibly do this in phase 3 trials? And if we were able to do that, I think there's more burning questions like new agents coming along, and I think this is a very smart way of doing that. Having said that, it's guideline informing, that's for sure, and we update our guidelines in Germany, for example, every year, so we can put that in. But it depends on the country. Some countries like the UK are very strict. They follow the label letter by letter, word by word. In Germany, you have a little bit more flexibility, you know. And then the patient has a contraindication against another agent. They have to use one of these modern combinations or something like that. So we're more flexible. I understand the US, it's the same. Once you have safety and efficacy data, you're a bit more flexible.
I feel, obviously, FDA approval is extremely important. I feel NCCN endorsement is something that payers will look for. And so even if a combination has not been FDA approved, if it is in the NCCN guidelines, it's a little more likely for us to get it approved by insurance companies. What was your experience when you tried to use the combination of imlunestrant and abemaciclib? Did you have to fight with insurance, or did you just show them the NCCN guidelines?
I personally did not. My 2 cases were actually Medicare patients, and I had 0 issues.
Yeah, approved with 0 copay after 2 hours.
Oh, wow.
Yeah.
That's wonderful.
Yeah.
So Sarah, you mentioned something before when we were talking about combination and single agent, and you mentioned response rate. Now, when we look at these curves, right, in those single agent studies versus the combinations, there's a little, well, a big drop initially with those single agent studies in the progression-free survival, whereas there isn't as much in the combination. Can you comment on that and what that really shows you when you're trying to think of who you're going to use which approach?
Sure. I think if you look at the SERD monotherapy studies, there's sort of a very quick initial drop in 40 to 50% of the patients that simply just are not benefiting from endocrine monotherapy, and that's alleviated somewhat in the combination studies. Simply because, like I said before, resistance mechanisms post CDK4/6 are multifaceted. They're not simply, in most patients, based on an ESR1 mutation. And so when you're hitting multiple pathways, you'll get less of a drop-off and more patients will benefit. And I think it's our task in the clinic to just figure out who are those patients that are going to have the most benefit from SERD monotherapy, because without a doubt, it's the best tolerated. Patients love being on SERD monotherapy. They feel great on it. And it's just trying to figure out who those are. For now, it's the ESR1 mutant patients who've had more than 12 months on their CDK4/6. But it would be nice if we could get a little bit more elegant about that selection.